Thank you very much for joining us for this plenary session. My name is Alison Ritter. I'm at the University of New South Wales at the Drug Policy Modelling Program, and I'm delighted to be facilitating this very important plenary session today. If I could have the first slide, please. Oh, do I need to be in... Something difficult and uncomfortable has been happening in the last year or so. And we've all been part of that trouble and that uncomfortableness. At the INSU conference last year in Glasgow, one of the keynote speakers left some people very upset, offended and angry. It could also be seen at the Harm Reduction Conference in Melbourne, where there were some activist statements made from the stage, and a number of people cheered and clapped. Others looked down and squirmed and felt enormously uncomfortable. I think this happens when we bring together academics and researchers with people who have used drugs in the past and are now in recovery, with clinicians who are providing care and support to people, with people who are still using drugs, and with activists. And this kind of upsetness and trouble happens quite a bit at conferences, and I hope most of you recognise what I'm talking about. It usually gets talked about in the tea breaks or over drinks or at a dinner around the conference. But it doesn't only happen at conferences, it's actually happening in committees, in Zoom calls, in emails, in collaborative teams, and of course around important policy tables where decisions are being made about drugs. In fact, it happens wherever we bring together a diverse set of perspectives. So on the upside, this means we've got the right people in the room. This means we've got a chance to make a difference and develop better responses to drug harms. On the downside, it means that people become offended, angry, upset. And I think one of the symptoms of this has been permission to speak. What's been interesting in the last year or so, thinking about this and talking with others about it, in my experience, I completely get that people with lived or living experience of drugs do not feel like they have permission to speak. I understand that there has been a power differential and there continues to be a power differential. I think what's interesting is that other people feel they don't have permission to speak. Senior clinicians, researchers, academics also feel that there is not permission to express a point of view. And I think this is where the trouble is. So what does one do with this? Well, of course, what I do is organise a panel at the next INSU conference, because what we've got to do is talk about it. We've got to talk about these differences, and we've got to make space to talk and to listen. So the aim of this session for the next hour is to have a conversation with 4 amazing people that surfaces these differences. So we are explicitly now not talking about consensus or agreement, we are talking about difference. And the goal is to allow it to be present. Because if we allow it to be present, we can recognise it and then we can respect it. So I'm enormously grateful to the 4 people that are joining me here. Julie Bruno from Canada, who is a clinician researcher. Louise Hansford from the UK, who is someone who no longer uses drugs and proudly in recovery. Sean Shelley from South Africa, who is an activist and represents people who are using drugs and uses drugs. And Margaret Hellard from Australia, who's a researcher and also a clinician. What we're going to do is proceed through 4 propositions. These are propositions that I've collected over the last year, so you may actually recognise some of them. And we're going to have 10 minutes on each proposition. And you will realise that these are difficult issues that represent some of the differences and the trouble and the uncomfortableness that we are going to surface in this session. So the first proposition is that, firstly, researchers should be objective, speak truth to power, speak to science, and, quote, stay in their lane. In the alternative, researchers have a duty to advocate for reform. And I'm going to invite Margaret to start the conversation about this first proposition. Margaret.
Thanks so much, Alison, and it's hard to find the exact words to describe how I feel about you having invited me onto this panel. Researchers should be objective, speak to science and stay in their lane. I absolutely agree with that. And researchers have a duty to advocate for reform. I almost agree with that, depending on what we mean by the word advocate. And the way I'm going to do it is by talking about my own story of why I think it's really important that we understand our role, but we also understand that we are not community. So I started off life as a young ID physician in the HIV era, where the voice of the patient was extremely powerful and was really fantastic in terms of basically beating all of the original learnings that I had out of me to make it that really think about what is my patient asking for, what are they needing, what is their requirement, and how do I help as a young clinician help them achieve that in an era when there was no cure. They were dying, all their friends and networks were dying. And so you sort of were in this slightly evidence-based zone so doctor knows best was actually not the case, but also recognising that we needed to do something to stop them from dying. And they wanted us to help them stop them from dying in terms of prevention. So that's how I got into research, but realised that at the centre of the research, the person and the communities that were affected had to be centrally involved. And it became innate. So for me, that's really important. And that our job, though, as a researcher, is to provide a sound, in my view, evidence base as best as I possibly can, as best as we possibly can, to support the affected community. But I don't think of myself as an advocate. I think my job is to speak really, really clearly about the evidence that I find and to ensure I try and get that evidence as quickly as possible to the communities that require it, so that they then advocate. And I'll use the example of hepatitis C in a moment for that. But also that, and I'm not saying I'm very good at this, in fact I'm far from perfect and I'm trying to get better at it, of making sure I'm constantly asking community what do they think is the critical problems and questions that need to be addressed, rather than me thinking that. Hep C cure, though, is an example of where, when that was coming along, I'd done work to show that people who injected drugs could be treated, and there were these amazing cures coming along, and I'd done work on networks of people who inject drugs, and that I suddenly thought, geez, we can eliminate this. Like, if we do this right, where is right is right. And a whole lot of people just said, no, only sick people should get this if you're in stage 3 or 4. And I can remember thinking, no, just go for it, treat everybody. But there was even a reluctance within community organisations, because of the expense of the drugs, to actually call for treatment for everybody. And I got into a heck of a lot of trouble early on with saying, no. And they said, oh, but we're going to lose money from here or there. And I said, that's not how the buckets work, in at least Australia. And we should be asked for the pony for Christmas. I can remember having a conversation with Jude Byrne about it. I said, Jude, I need to come to your meeting, mate, and I need to tell you to ask for the pony. Ask for treatment for all, get up there and do that. Same with the hepatitis C folks. They were sort of thinking about it, but they were anxious. So sometimes also, I'd say that I was, at that particular moment, being a little forceful about requirements of the evidence that I was seeing, and maybe it wasn't the communities didn't feel comfortable initially, but then they went out and asked for the pony in Australia, and we got it, and it's been a treat.
So some people really think that researchers should be advocates. Does anyone want to speak to that position, or comment on Margaret?
Yeah, I guess for me, sometimes being from the community, your voice isn't heard, and researchers have a lot of influence and a lot of power in some respects to get the research out there. So when we've been trying to bring in interventions, they have to be evidence-based. So you have to kind of get a researcher on board. So I absolutely believe that researchers are there to do a role, but then, you know, I think there is a case to be made for using that influence to help change, which could be called advocacy.
Because of the power that, that researchers have, yeah.
Well, maybe I'll give an example. In my early career, I happened to contribute to open the first needle syringe program, so I was really into it. I also ran a cohort, and early results from our cohort showed that in Montreal, HIV seroconversion was associated with going to the needle syringe exchange. So I think what I want to bring here is that as researchers, as generation of evidence-based, we have to look at the data as researchers, as neutral as we can, and then explain the data. In Montreal, it happened that that result was probably a consequence of the needle exchange program weren't adapted to cocaine injecting like 25 times a day, and they were giving like 5 syringes. This is what we put in the paper. So I think in a way, the researchers has to stay in their truth of the research. Then I also think that when it happens that we have results, whatever positive or negative, we certainly have we have to go and do some real dissemination with communities, policymakers, etc. That's not necessarily advocacy, but it's also bringing the results to change policies. I think that's the nuance I would give.
I mean, it's such an important reflection, Julie, about when a researcher finds results that one knows community are going to disagree with or are going to find extremely difficult to deal with or manage. And I think that's a very stressful and troublesome situation.
I think for me, when you think about it, if you want to bring a whole lot of kids in off the playground into the classroom, you know, it's much easier to get them to come in for story time than it is for maths time. Okay, and data doesn't really sway a lot of hearts. You know, and the mind always follows the heart. So I think to separate the two roles is difficult. Researchers should be working with the community because research must be relevant, and whose research are we talking about? You know, I reckon in the field of drugs there are a lot of people at NIDA who've never actually spoken to people who use drugs regularly. So I think both of these things are true, but of course a researcher who gets too much on a particular bus often finds himself in a difficult position, because what happens if some of their data now contradicts their advocacy position? And that's very difficult.
Yeah.
So I would say researchers should work with community members, and the right people have a role to play in turning their data into a narrative that's meaningful with the help of the community.
Yeah.
And Alison, I just wanted to, as well, I do work with Aboriginal communities in Australia, and they might even object to some of this notion of what we call research and storytelling, lived experience and all of those things, and that we're coming from a Western paradigm of research. And I'm really conscious of that with our work as well, of how I have to think and constantly rethink and have discussions about that. So even, say, the way this question is framed even might not suit everybody as well.
Sure.
And in Australia, if I was working with some groups, I would probably be really having a conversation about what's the nature of that, sort of how we have to even frame our thinking, because invariably I have to really step back and have a big think about stuff, because also it does challenge the notion of that's my truth. And I'm thinking, well, my truth is just your opinion, but how strong should that opinion, if it's embedded within a community culture, and so there's a cultural truth to that, but if that cultural truth is against an outcome which is really, really not great. So it's a very long and slow conversation about actually what's the requirement. So I also just want to highlight that as an issue. For me, in some of my work, is really trying to think carefully through a cultural truth, which is a truth,
Yes.
and how that though then, you know, and that might be in all sorts of things, but might put you at risk of HIV. And an example would be that if sharing a needle and syringe is actually part of your cultural truth because you share everything, yeah, but that actually transmits HIV. So we have an outbreak of HIV in a community. So what's the conversation about the cultural truth? Both are true, and one is leading to a really bad thing, but also breaking cultural truths is also complicated.
Yeah,
So-
and I think everyone here is committed to meaningful collaboration between researchers and community. I mean, that's kind of your point, Sean. But I think we perhaps don't appreciate how hard that might be for researchers and for community, and that there are some fundamental differences and tensions, and, you know, your truth, my truth, cultural knowledge versus, I don't know, data knowledge, and so on. Okay. The second proposition. Best lives are lived without drugs. In the alternative, we don't have anything to recover from. And I'm going to ask Louise to lead the conversation on this one.
Gee, thanks. Yeah, I think for me, you know, I'm used to it being a good thing that I don't take drugs anymore. And when I was in INSHU in Montreal and really ingrained within the community day there, you know, I was the anomaly. I was the person that was the odd one out, and it was quite uncomfortable and quite challenging for me. But let me tell you, if I could smoke crack tonight and be sat here tomorrow, I would do it. But that isn't my drug use. My drug use is devastation, degradation, prisons or hospitals if I'm lucky. You know, and I think for me, you know, you know, it is a bit of a cliche, but I have a life beyond my wildest dreams because it's not necessarily because I don't take drugs anymore, because I'm still me. I'm me with drugs, I'm me without drugs. Am I the best version of me with drugs in me? Absolutely not, because I'd be running around stealing your credit cards and you wouldn't even know that I'd done it. You know, that's my drug use. You know, this whole notion of recovery, you know, like there's kind of this debate going on at the moment, and you know, and I'm speaking to people about it because it's okay to acknowledge the difference and the different opinions, and I don't have to force my will on anybody to make my opinions right, because, you know, I'm not God. You know, just because something works for me, it doesn't mean that it's going to work for anybody else. But I did get offended when "stay in your lane" is used about kind of me and my voice. I find it really offensive. You know, I may not have injected drugs for 20 years, but I'm sat here with reoccurring cellulitis because of my drug use. You know, my drug use from 20 years ago still has an impact on me, my family, me travelling. You know, so I think I had a broken hip that went undiagnosed because of negligence. I had hepatitis C, I had hepatitis A, I had osteomyelitis. You know, so in medical terms, I absolutely had lots of stuff to recover from. You know, I had to recover from what I put my two elder children through. They didn't know whether I was alive or dead. You know, and I think we can get really hung up on language. You know, when I go to where I go to get recovery, I say, I'm Louise, I'm an addict. I don't have a problem with that. You know, but I wouldn't sit on a panel like this and say, I'm Louise, I'm an addict. It's not appropriate. You know, so I think it's, you know, what does even recovery mean? Do you know, what recovery means for me is on a daily basis, I do the best I can. And that, for me, means no drugs, because I have enough evidence that I don't do the best, I'm not the best version of me. Yeah. You know, honestly, if I could smoke crack cocaine, you know, I'd still be doing it. But I have got enough evidence that me and crack cocaine doesn't mix. You know, you know, am I envious? Absolutely. Sometimes when I see the community going off to score at a conference, there's a bit of me that wants to go with them. But but I wouldn't be coming back the next day.
Yeah.
So I think we don't have anything to recover from. You know, when I was in my drug use, I was very defensive about my drug use, and I had lots of people telling me I should stop. Prison workers, social workers, doctors, everybody I came into contact with. You know, and it isn't until the benefit of kind of moving away from that and becoming the best version of myself that I can kind of look back at those times and act with a reality.
Yeah.
But my drug use is very different to other people's.
Yeah.
You know.
Thank you. Thank you very much, Louise. Sean?
Yeah, so in all my work, I've got one objective and one kind of world that I look forward to, which is a world where most of the time people can make conscious, well-informed decisions about whether to use, not use drugs, how to use them, and not face external consequences such as arrest and stigmatization. So I really have no position on whether somebody uses drugs or not. What I can tell you, being a dependent drug user in today's world is a pain. You know, traveling is difficult. Knowing your dose is difficult. There are lots of challenges with it. You come into contact with people you don't want to come into contact with. It costs undue amounts of money. But frankly, it's easier to buy methamphetamine than it is to get methylphenidate from a psychiatrist, and cheaper as well.
Yeah.
So somebody with ADHD, I understand that fully. I think that on both sides there's defensiveness. Because for a lot of people who continue to use drugs, there are challenges which may be external. They're not from the person themselves. They would do fine if they could get a prescription diacetylmorphine, for example, heroin, as opposed to having to buy unregulated heroin off the streets. They would do great. But it is more difficult when you're doing, unregulated drugs. So there's a bit of defensiveness from both sides, I think. I think the one problem I have is the recovery word has become politicized. And in the United States, you've got recovery schools, recovery houses, recovery halfway houses, recovery employment, recovery jobs, recovery training, recovery universities, and those are all predicated by urine test. So if you fail your urine test, you lose all of those things. And so that I've got a problem with. I prefer to use the word resolve personally, but it's a personal issue. And frankly, if somebody chooses not to use drugs, great, well done to them. It's not my choice, but that's okay.
Thank you. I mean, one of the things that's been interesting is the development of language. So having worked in the field for a very long time, we didn't talk about it at all. Then we talked about peers, but no one quite knew what a peer was. And then there was living experience, and now there's lived and living experience. So that's the terminology that's certainly used now in Australia. And in a sense, it categorises. You just need to make sure, am I talking to someone with lived experience, i.e. someone who's no longer using drugs, or am I talking to someone with living experience? But I don't know what people think about these kind of categorisations and this sort of way of trying to manage the diversity of experiences with people who have used drugs or are using drugs.
Maybe I'll bring the clinical perspective of saying,
Sure.
in general, when you have a long career like me, you've seen the trajectories of your patients in and out and in. And at each of those transitions, which are in general because at some point drug use is not comfortable anymore, and other times it's different, and other times it's relatively under control, meaning socially speaking, there is a loss of something when you're transiting. Using drugs is also having friends, community, support. The support within the community of people who are using drugs is very important.
Identity.
And then when you stop drugs, you lose that thing. And I think it's very underestimated with the programs and everything. But working with populations who have been in these trajectories for decades, the system of treatment is almost not important anymore because those who who adhere to these treatments are already there, but those who've been through four sets of treatments in general, what they need is something very, very different. And one of the things that when you're trying to transition to stop drugs or reducing drugs, then you have the grief of losing your friends and family and user family. And I think when Louise is speaking about this, is also that you feel like it used to be your family, and
Yeah, and it's this, you know,
Well, it's
identity.
a constant sense of othering. To me, this
Yes.
is what I find really, and it doesn't just apply in this area, this is constant sense of trying to create the other. So this notion of lived or living experience. Now, Louise is still having a living experience related to drug
Still
use,
with us.
as opposed to a lived experience as if she wasn't there anymore.
Yes.
But I know there would be people in this audience that would argue with me about that, really, and I respect that. But I do think, I often think that, and I agree, usually I see this sense of, if you're not behaving in a certain way, you can't be part of this group. And it's not even necessarily always overt or not, and that's in all sorts of things in life. Makes it difficult for somebody sometimes when they're making choices about what they want to do next. But I think it's also a very human and natural thing. So I think it's a constant human thing to other, and we've just all got to be conscious of it and try to do our best not to other.
Yeah.
And maybe just add a little thing is that from a clinician perspective again, when a person is coming in those trajectories where they're ready, I don't think we're ever thinking as, is this person is best living, is
Sure.
life or her life with or without drugs, or is recovery is good. It's basically, okay, what do you need now?
Yeah.
And I go back home myself with my life, and they go with their life, and I'm just there as a support. You have to be humble in these things. You're not the ones who
Yeah.
stop people or using drugs.
Yeah.
I think for me, you know, like we can get hung up and we end up segregating people, and for me that doesn't sit comfortably, because first and foremost I'm a human being,
Yes.
you know, and I think it, you know, I want to be in places that are inclusive, you know, and I just think it's about including people, and who gets to say whether I should be part of something or not? Surely I should get
to
that
decide?
choice. I get to decide.
Yeah.
So yeah.
Thank you. Let's move on to proposition number 3. Clinicians have extensive expert knowledge about the best medications, and in the alternative, clients know their own bodies and are best placed to judge what they need. Surely.
Yeah.
Do you want to lead us off on this
Yeah.
conversation?
I mean, it's quite interesting because it's, in a way, it puts together two knowledges and then oppose them one to the other. When you think about it in medicine and clinical, particularly in family medicine, it's always about patient-centered, whether it's asthma, diabetes, etc. And we know that most of the treatment, people don't even adhere to their treatment, they don't take their pills. So in some ways, these questions are not just specific to the drug use disorder or drug use situation. For me, when a patient is coming, because obviously I don't go in the street and try to get them in, when they come, it's because they have some kind of question or they want something. The first thing is to understand what they want. And if we don't build any kind of relationship or beginning of an engagement or trust, nothing's going to happen. Sure. Whatever you want to prescribe, whatever they want you to prescribe to them. So it's more about, and then when you get to this space where you have to say, okay, now we're discussing what you want and what I can offer, then both knowledges are important. If someone has been on OAT for 25 years and they've been through buprenorphine and then methadone and then K and whatever, the first thing is, okay, what do you think you need? That's fine. On the other hand, I had a patient the other day who came in and, you know, with the safer supply in Canada and everything, she was really new to she didn't know much, but she had this very assertive stance of saying, you give me KDN and Dilaudid, without having this space to discuss. And then it ended up okay. But I mean, I think it's more of this way of trying to find where is the place where we work together, because it's a long-term process. Whether or not people are retained in your follow-up, it's a long-term process.
Yeah, thank you. Other comments on this particular difference? One of the things
I'm just going to say, again, I think clinicians do have extensive experience about the best medications for somebody. But also, people do know their bodies, because, as I say to people, I'm not taking the medication. You know, so when I'm about to start somebody on a treatment program for either HIV or Hep C or hepatitis B, I tend to just do the bloodborne viruses these days. I don't take those tablets. And I don't walk in their shoes, and I don't know their circumstances fully. I mean, we have a conversation about it, of what's going to make that difficult or easy, or why or why not, or even, you know, sort of lipid medications, whatever, to go with your HIV. So to me, it is really important that you go, I know these medications are really good in this way, but I'm not you and I'm not taking them. And also when I start people off on new treatments, that there is a conversation, like, you know, you kind of make sure that you provide them with an opportunity always to contact you or somebody, is how I do it, by telephone, if things aren't going as expected. So you can only say this is mostly what happens, but sometimes, because everybody's different, things don't go as expected. And make a phone call if this is not going. For me, this is what I say to people. You offer the opportunity of what to do if things don't go as expected. And I find that gives people a lot more confidence that they're not just being sent off. You never get the call, to be perfectly honest, or so rarely that it's not like it's an impost on the health system or anything. It's just this sort of small offer, which is rarely ever required. Because occasionally things don't go as expected, and you don't want somebody to feel foolish, and you don't want somebody to feel, I'm going against what the doctor says, because constantly people are trying to please you in a way that is unfortunate and tells you something about circumstances of power imbalances. So you're trying to give them that out of choice.
Yeah, I mean, that's one version, is that clients are trying to please the clinician. The other version is that if a clinician hasn't used drugs, they won't be able to help me. They won't understand. They won't truly understand. So that's another perspective that has been expressed.
We hear that an awful lot. I mean, my personal experience is, you know, for 9 months, I knew that I had something going on in my body. I went backwards and forwards to a hospital to be told that I was just a drug addict and that I didn't know. I had a broken hip, and by the time they found it, I had osteomyelitis, and the break in my hip, I had bits of bone coming out of my leg. Do you know, so in that instance, I absolutely knew my own body. I think, you know, when I started a project with the Hep C Trust, where they've got this lovely slide that talks about who's the best person to tell you about a liver condition. Is it Prang Steve? Not really. You know, so for me, I think that, you know, you need that balance. You need somebody that's educated and understands the drugs, the contraindications and all of that. But you also need people to listen to the person in front of them. You know, because I do know, you know, like I rang my doctors yesterday, said I've got reoccurring cellulitis, my script's ready for me to pick up at home. You know, they listen to me. You know, there's some doctors in that surgery that don't know my history, and I refuse to talk to them because of how they communicate with me.
Okay.
I think it's all about a relationship.
It is. I mean, I think that was Shirley's point.
And that's exactly the point that you're making. I also think that a lot of doctors don't necessarily know the ins and outs of the full agonist spectrum. And we've got to remember the Zinberg's principle of drug set and setting. Everybody's different, every context is different, and it's not a predictable chemical cascade when you're prescribing to somebody. You've got to listen to the person. And in particular, my problem is when a clinician tells somebody, minimizes their pain that they're experiencing. That's particularly problematic. Or just doesn't listen to them when they talk about side effects. But fortunately, most of the clinicians I've worked with, and I've worked in a few clinical settings, definitely aren't like that. They're very present with the people, and it's a collaboration.
Yeah.
And just maybe to give a perspective different than, because we're experienced doctor, but I had a resident recently, I had a patient coming to the clinic. She was very vulnerable. She was at the point of her life that it was really hard to come. She went to the emergency twice or 3 times, and then finally she got to the clinic, and my resident began to see her. And when you don't know, when you're not experienced, so she went into the list, what is your psychiatric history? She did the 1, 2, 3, 4, and the patient walked out 5 minutes later because it didn't make any sense. But there is a sense for many, many doctors not experienced with people who use drugs that they have a person, they don't have a person in front of them, they have a drug users and then other things, which is education training.
So let's go to the 4th proposition, that some people might recognise the second half, which was said at a conference. Public health provides evidence-based interventions to improve people's lives. Or in the alternative, public health is a system of oppression. And I'm going to ask Sean to lead us off on this one.
This is one of my favourite subjects. Sure, public health can provide evidence-based interventions to people, but it can also be a form of oppression. And we're not going to go into the post-structuralists and Foucault and Derrida and all the rest. But I want to talk particularly from the perspective of people who use drugs. There is a definite move towards the over-pathologization of people who use drugs. The whole NIDA model of the progressive brain disease, drug addiction is a progressive disease of the brain that, left untreated, will result in death and compromises free will. I think that's the way NIDA describes it, or Nora Volker describes it in the one blog post. Well, none of that statement's actually true for the majority of people at population-sized studies. And the problem is that as we move towards this very regimented kind of public health system, and in particular the biomedical success of harm reduction has kind of compounded this problem. Because now we see harm reduction as being targeting opioids in particular. It's OST, it's needle and syringe programs. We forget about all the other things. No, harm reduction actually comes from an anarchist ethical background, anarchist ethics and philosophy background, and it's thinking more broadly. Public health should also, in my mind, think more broadly. It should be thinking about public well-being because, we talk about an enabling environment, but the doctor just looks at one particular thing, not because of the doctor's fault necessarily, but the system is constructed in such a way that we've got a lot of divisions between different things. And so if you're talking about opioid substitution therapy in the United States as part of a public health system, well, then I would say definitely it's a form of oppression because, if you've got a pain problem that they're treating with methadone, which is not a good idea, by the way, for a variety of reasons. Most of the overdose deaths in the United States were because of methadone patients who were being treated for pain, not for drug use. You can't get take-home doses in the first while. You can't transfer to other clinics. You've got to see one doctor. You can't go across state lines. You can't move. But if you're going just for pain, you get a 30-day supply. It's definitely a form of social control there in that system. And we are moving more away from the criminal justice system, more towards a biomedical pathologization of people who use drugs. And somebody's worked out that you can charge patients a lot more than you can charge prisoners. Now, if you've got a lifelong disease of the brain that compromises free will, you've got a really great excuse to keep people in a system. And now with Volker and McClellan proposing a thing called pre-addiction, we've got a problem. So in that context, I would say a public health system can be a tool of oppression, but I don't want to offend all my doctor friends, and I work in a family medicine department, and that definitely we are trying to get a more integrated approach. One of the things I'm doing at the moment is designing health systems that address drugs as well in an integrated fashion. So I prefer public well-being, looking at the whole person as a whole, and combining the social development in South Africa, the Department of Social Development aspects with the Department of Health aspects into one thing. Yeah. Otherwise, we've got that problem.
Thanks, Sean. Margaret?
Well, as much as I'm attracted to being part of a system of oppression, it's got something nice about it. Yeah, I totally agree that we have to ensure that, number one, we don't confuse what I'm going to call clinical medicine, where we at an individual level are doing something and then say well, that's, if we do it to a whole lot of people, that's public health. Because in my view, I don't call that public health. I call that clinical medicine pathologising people in a way that they shouldn't be. Which is, and if I'm for people, I'm an infectious disease physician, I'm a public health physician. When I think about my public health work, I actually don't think about an individual or all of those things. I think you say you have to be incredibly careful. As well, I do think that we have to be incredibly careful about over-pathologising difference, what I'll call neurodivergent difference, and that we, and I see that happening, and I just think it's really important that it's more to me, rather than what I'm going to call public health as a system of oppression. For whatever reason, we want to pathologise a lot of stuff, and that brings something that is within a range of behaviours into the health system, or sometimes clashing into the justice system, and I think we've got to be really careful about stopping over-pathologising.
But if we think about classic public health, so let's take masks, for example.
I was going to say, let's take Jon Snow whipping off that pump handle. But yeah, I go back, I diverge.
So, the notion of public health is that is a sort of, one version is the paternalistic notion that people should do something on behalf of the whole community. And that then rubs up against rights, perhaps the right to use drugs, the right not to wear a mask in the case of COVID, the right to use methadone in ways that the doctor has not prescribed. And I think that's where the tension is between the individual and the kind of broader public health, the well-being of the whole community being expected to be supported by individuals having their own, I hate the word rights, but anyway, having their own rights removed. I think that's part of where it runs
So
out.
there's some basic places where you can go. We've got the clean water supply.
Yeah.
Okay, and most people would reasonably agree you don't go and shit in it. Like, quite literally, you don't go up to the reservoir and take a dump.
Yeah.
Well, so if we're all... There's places where we've got an absolute shared understanding that is a very reasonable thing, that I don't put my sewage into the clean water supply.
That's right. You'll be tweeted on this, by the way, Margaret.
Oh. I didn't think people did X anymore because he's not exactly a cool guy. So what I'm saying is, if we start with a shared understanding that we do think there are some shared things that we all agree with, or if somebody wants to argue with that and say, actually, no, I personally do think I have the right to put my sewage in the fresh water supply. But so if we just start with, at the extreme end, we think it's reasonable.
Yeah.
And then as you walk along, you're constantly in public health, trying to find a balance of benefit and risk. Yes. And you've got to then suddenly realise that you get to a place where, hang on a ticky, this is getting a bit controversial.
Yeah.
But all the way down from, if I'm going to get tweeted, I won't put my sewage into the public water supply.
I think you said dump.
Oh, I know that, but I realised what you said, so I thought I'd better be better. To this issue of, say, masks, and when does the public, under a particular circumstances of no vaccines, blah, 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 as opposed to later on. So there are always these balances, and I don't think we necessarily always get it right.
No.
But there are reasonable times to expect, in my view, us as a public to behave in a certain way to protect vulnerable people in our community.
Yes.
But maybe what Sean was describing as public health, for me, is much, much more the moral control of a mixture of society, corporation of physicians and healthcare worker, translated through what seems to be public health, but actually they're not public health measures. They're just control measures that are supposedly based on protecting the population, but it's not based on evidence that much. So, but on the other hand, public health in the world of drug use has also been the driver a lot of times of policies of, in Canada, consumption rooms, policies towards having syringe and,
Public health has been very positive in that.
so it's, I mean,
I was just going to say, I can argue on both sides of the fence. I mean, I had to be 2 years drug-free to get interferon. You know, it's like, what's that about? You know, and ironically, I did interferon when I didn't need to do it. If I hadn't have done it, when the osteomyelitis came back, 5 years later, I would have died. You know, so I was grateful. But then you've got, you know, like, smoking, we don't so like the main public health things in the UK are smoking, diabetes, heart. We don't control the people in the same way that we do for drug use. We don't. You don't have to go and pick your inhalers up once a day. You don't have to, you know. So I think, whilst I absolutely believe in public health, I'm a registered public health practitioner, you know, I do think that there are elements of it that are really oppressive.
Yeah.
See, I wouldn't call having to pick up methadone once a day public health.
no.
I actually don't call that public health. I call that clinical something or other, and I call it nonsense. But I don't, that's not how I frame in my mind as a public health position.
Yeah.
Public health, that's a part of a really non-evidence-based clinical service that should be changed.
Yeah.
And that as a researcher, public health specialist, how do you provide better evidence to stop that clinical nonsense?
Yeah. Did you want to add any final comments before we move on?
Just finally, you know, it is very dependent on who is implementing the system.
Yes.
You know, and look, I lecture fifth-year medical students, and fifth-year medical students know more than God knows, you know. Honestly, with due respect to all my doctor colleagues, they think they know everything, and the way they implement any health intervention is pretty much like a regimen, an algorithm, bang, 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 bang. And unfortunately, that translates often into government systems and even funding systems that are very regimented, very controlling. And for example, it was very interesting to hear people say that drug consumption rooms are not a biomedical intervention. They're more of a social intervention, which I thought was a very important point to make, because nobody wants to go and drink their beer in a clinic.
Yeah.
Okay?
Yeah.
And the problem is that when we have these available, the punishment for using outside of those spaces becomes worse.
Yes.
And so what can be a very good intervention suddenly becomes quite a bad intervention. And the moralism of not turning existing drug sellers' consumption rooms into better equipped consumption rooms, you know, it becomes a problem. So it becomes very blurred what is public health and not public health.
Yeah.
It should just be public integration and access to everybody for whatever health needs they need.
So some research on the negative consequences of drug consumption rooms might be in order, Sean?
No,
teasing.
I'm advocating for them, very much so.
I'm teasing.
Yeah.
We've tried to surface some of the issues, but there are many, many more. And in fact, we've got a long list of other things where there is trouble, upsetness, anger, tension, difference. Now it's your opportunity to contribute towards that. And so the floor is open. It's not Q&A. And I would ask that people, I mean, you can ask questions, but I think it's an opportunity for you to talk about the things that trouble you about difference. And I'm going to ask that people keep their comments very, very brief so that we can fit in as many as possible. And we're going to start right up the back and then down here. And I better put my glasses on. Thank you very much.
I'll be like an auctioneer. I'll scan.
Incentives. If someone is experiencing poverty, can giving them something that enables them to actually live, e.g. cash, actually be an incentive? And the other side of it is that this isn't an incentive, this is actually mutual aid. And by calling it an incentive, we're doing a massive disservice to the people that we're actually trying to work with or to help discuss.
Thank you. Well, we're probably not going to quite discuss it, but you're surfacing the excuse me, you're surfacing the tension between whether giving cash is actually welfare aid support, or whether it is actually an incentive for someone to behave according to the paternalistic direction of the person who is providing that incentive. That is a great difference and a really good point to make. I'm going to collect a few before I
I'd
toss
just
to
like
the
to
panel.
respond to that, because honestly, the arguments in the UK, how can you give somebody that uses drugs £10? What if they use drugs? Do you know, it's...
Sure.
Yeah.
Sure. We're going to go here.
Thank you so much. Great discussion. I think as an early career researcher myself, one of the points that I struggle with is how academia defines impact versus what is social impact. And then I think academia and research funding bodies are incentivizing the academic institutions to turn into publication machines and value research as number of publications, number of grants, blah, blah. While research that has real impact, which is in partnership with the community, takes time. The relationship building takes time. Everything takes time. It's not as productive, and sometimes it never leads to a publication. But that's not valued in academia. So I think that's something that I struggle with.
So the mechanisms to reward differ enormously, and the mechanisms of reward for academia don't bear resemblance to the mechanisms of reward and collaboration with community, and that creates enormous tension for academics who are expected to succeed in the academic system, which rubs up against succeeding in terms of impact with community. So we're surfacing difference.
This one over there.
Hello. Nice to see you.
Hello. Oh, geez. I was just going to add, for the last discussion, comparing like diverting methadone to like defecating in the public water system, I guess it's just, I think that ignores how if I were to take all of my take-homes and boof them at one time, like that impacts me, like I'm not impacting the people around me. So I think there's like a big difference between like the actions of most people use drugs and like not wearing a mask, or like antisocial behavior that's like harming the community around you.
Right. Thank you.
So I just wanted to add that.
Thanks, Danielle. And we're down here.
Hi, I'm a writer and an activist, and I think one thing that is really important is, besides listening, the language that people use, because sometimes people who really have the right intentions are not aware that the language they use sounds pathologizing and off-putting. And this has really negative results because an opportunity for learning and collaboration just gets blown because people really shut down when they're referred to in a negative way. And I think, you know, I'd love to invent software that just pops up and says, we're not using that term anymore. Now we're using this one.
Sure.
But I don't mean, you know, censoring people or being some kind of language police.
So, but this is the issue. The language police is the issue. So yes, I think we all agree, and in fact the conference opened with a statement about the importance of language. And yet you end up with, I think it was Louise commenting that she can comfortably use the term addict in certain circumstances. And then you end up with the language police issue, which creates tension and trouble, and there'll be people out at the afternoon tea saying so-and-so used that word. How do we allow words to be used? Yeah, go on.
Well, I think people have the right to describe themselves the way they want.
Yes, absolutely.
But you get into trouble when other people start describing you or others in language that that person doesn't use for themselves. And I sort of look at it as a fundamental principle of respect.
Sure.
And also of taking a little time. And I don't want to be too wordy, but I just remember years ago I worked at a drop-in center for street youth. Most of them were doing drugs and doing sex work. And these young researchers came in and were like, we're writing papers about you. And they told them all about basically their own lives. And the people I was working with were like, boy, are they stupid. Why did they have to stand around for months? And I just thought, no one has ever taken the time to say, the world doesn't respond as well to something they hear from one person as they do on a piece of paper, and this is a way to get money to keep the drop-in center going.
Sure.
And if the conversation had started out that way, the researchers would have left with things that were really interesting and valuable, and the people who were in the drop-in center would have felt like, oh, someone really listened and paid attention to me. So,
Yeah.
I'd like to
Thank
add
you.
something about the language, because the flip side of it is many times you see clinicians with the best intentions and really want to learn and really want to do something, but man, this language thing is complicated. It's getting
That's
more
right.
and more complicated. And then they're getting they're getting very negative feedback from just not being able to have the literacy, to have the right words at the right place, just because it takes some experience. So I think there is a flip side to that language that I understand completely, that people wants to be respected, and the language is kind of a traduction of a respect, but there is the flip side as well.
Yeah. Some more quick comments, Matt.
Yeah, I think language is very much about context for me. It's about what people's intention is. So when I'm going around the world helping people mobilise as people who use drugs, people often pick up the language from the dominant ideology and describe themselves as addicts or describe themselves, partly because there's an expectation in the system sometimes that that's how we are accepted if we play those roles. And over time, I mean, I don't get offended by that. I mean, for me, I think people can describe themselves how they like, but there is a sort of activist conversation over time to start saying, look, no, there's a way we use language because it's about our liberation, it's about our rights. But also internally within the community, someone calls me a junkie, then that's an insult. Within the drug using community, junkie is a protected term that describes people who inject heroin. And I think we'd be very respectful of actually not using that if you're not an injecting heroin user. So I think there's a sense of how is that word being used? What's the intention? Yeah. When I went to my GP with serotonin disorder, and had addict written across the top of my file, that's then denying my right to health. And that's suddenly a very different experience. Now, a doctor discriminating against me and taking away my right to access very needed healthcare in that moment.
Yeah, thanks very much, Matt. We've only got about 3 more minutes left. If it's really, really quick, and then we'll need to summarise.
Yeah, I just wanted to pick up on something Louise said about being able to speak to some of her GPs and not. And you may also be able to relate to the fact that maybe somebody that was in your position before couldn't get health care because they didn't have a GP. And I want to say the differences are, when I work in forensics, is that my patients don't have a GP, so care stops. That is not fair.
Thank you. So I will say that we are continuing this in the discussion space at 3 p.m. this afternoon. So anyone who'd like to come and continue talking about this, I'm going to invite each of the panellists to make any final comments about the trouble and the tension and the difference that they might have experienced. I don't mind. We'll start this side, Julie. Any final comments? Anything that hasn't been surfaced that has been
I think it's really a beginning of a very crucial conversation that we have to have moving forward. I think we just scratched the surface. We were pretty consensual, so maybe next time we should have, we should be more,
Thanks. Louise?
I think for me, it can be really segregating and shaming. When I've used the wrong word and somebody points it out, it makes me want to withdraw. I think we're all predominantly we're all here trying to do our best, and it's okay to have differences of opinion.
That's right.
For me, one of the things that I really, really love about Inshoot is I can do the community day as the only person that didn't use drugs and be welcomed, be valued and heard. You know, that I don't get that in other communities. I get, well, what do you know? Stay in your lane. You haven't used drugs for that amount. What can you bring to the table? It's really offensive.
Thank you. Thanks, Louise. Sean.
In conclusion, I think that my stance has changed. We need to have a conversation. It's not a debate. It's a conversation. So when people, in what I've done, when people bring up other language that's maybe offensive, I just keep using the same language. I model the language that I'd like to use. And you know, that seems to work with a lot of people. I'd encourage people to read Magdalena Harris's paper called Generous Constraints on how a public health system and the supply of methadone can be tailored, protecting the rights of you know, the health and well-being of people, but at the same time allowing altruistic diversion of methadone. And it's a really good example of how public health can stop being, in that particular circumstance, not all public health, in the case of methadone, stop being quite draconian and probably the wrong word, but quite rigid and controlling. And at the end of the day, I've got a brilliant slide which I usually use. I love the term people who use drugs, because 9 times out of 10 you can just put a full stop after people.
Yes. Yep. Thank you very much, Sean. Margaret.
Reduce or stop othering, and I just think it's respectful conversation.
Yeah.
Correct.
Our goal was to enable us to talk about these tensions and these troubles, this upsetness, being offended, and to do it in a way that gives permission for that. And I hope that we have demonstrated that, my panellists and I. This is about recognising difference, respecting difference, and it's ultimately about sharing power and everybody sharing power. Can I just close with where the conference opened, which was Angela McBride, who put up a beautiful picture that in the middle of it said, engaging with an open heart. And I encourage everyone to engage with an open heart and surface difference. Thank you very much, everybody. Please join with me in thanking the panellists.